So if we jump into the objective assessment, there's so many different things we can measure. Essentially, we want to measure gait. Can they walk? Can they jog? That tells us so much about prognosis and how they're moving. Really have a good look at that. The observation of trunk movements, squat movements, a really great analysis of lower limb function. Palpation is a really big thing like we talked about. Flexibility in terms of passive straight leg raise, knee extension test and the hip flexion test. Obviously strength testing, we know that's a big factor that's going to be prognostic indicating. And then I always look at bridge progressions as well because it shows me where they're at functionally as well. So if we jump right in and have a look at the gait assessment. So first of all, we just want to have a look. Have they got crutches or no crutches? If they're covered on crutches, obviously we're starting a little bit further back. Is their gait normal or is it abnormal? Are they doing it with pain or without pain? And I normally look at this time, I'm checking them out in terms of is there any bruising or swelling? What am I noticing elsewhere? And then if they're walking fine, we'll look at a jog as well. And that didn't play, but that's okay. So the big thing with the gait assessment, I really want to look at them from front on, behind and side on as well. So just don't look at them from front on and say, yeah, they're fine. You want to have a look at all angles so you can pick up any differentiations and target gait patterns that we can address as well. Because if they're moving with an target gait pattern, it's more likely to be loading the muscles in a different way, and we want to try and normalize those patterns as much as possible from a neurophysiological point of view.
And Jo, do you also just ask them, do you feel like you're walking normally? Like I've had a couple of strains and yes, I could walk pain-free, but there was just something that, I just wasn't completely relaxed in my walking.
What I tend to do is I will video it, and then if I see anything, I was like, did you feel anything? This is what I noticed, and show them, and they're like, oh yeah, I thought I could feel something. And then explain to them, because they can see it, explain to them what that means and why we need to correct it. And then, occasionally you'll have someone that comes in kind of dragging their leg, and, those people we might have to say, hey, I think you're better to be on crutches for a couple of days if they're that bad.
Yeah.
The next thing I like to look at just really quickly, so they've basically walked back and forth, I've had a look at their trunk movement, so trying to see if there's any pain or stretching felt when they just bend forward into trunk flexion. And then I also just look at lumbar extension, side flexion, everything, just to see if they're having any issues, if the back possibly is involved in this process at the moment. And then we might look at single leg trunk flexion and look at a tibial internal external rotation bias depending on where they're at. It's all going to depend on the athlete's irritability. When I do look at those trunk movements, what I tend to do is I'll measure from the floor to where they touch on their shin. So there's that benchmark there, and I've done it where I've measured with like a piece of paper, and because I haven't, I've been at a track or whatever, so just being able to have that benchmark for the athlete in terms of that flexibility of the trunk will help you. And as I mentioned, I like to also look at squat assessment. Squat is a really good assessment of just general lower limb function, what's happening at the hip and the knee. I look in terms of both legs, so can they do double leg squat to 90 degrees with the bench behind to guide the knee flexion? Are they moving away from the bench? Are they hitching to one side? Are they protective? And then if they're doing that fine and you're quite comfortable, you can look to progress that to a single leg to 45 degrees. Most of the time, the more elite athletes that are doing pretty well, that are walking pain-free and potentially jogging, they're going to go straight to that. So you need to make that clinical decision, and all these assessments, if you know that that's not relevant for the athlete, you can move past that quite quickly.
Yeah, that's a good point, especially when you've got limited appointment time, just to, streamline it.
Yeah, so these are all things that you can assess, and I want you to know what's available to you, but you don't need to do all those things if it's not relevant for your athlete. So, functional objective findings with Jala. She was walking pain-free, but she had pain when she tried to walk too quickly. She had trunk movement that was limited by pain, just with some pulling mid-shin. and she was 20 centimetres from the floor with a VAS of 7 out of 10. She had 8 out of 10 with a single arabesque, and she had some pulling about 5% when she got about 5 centimetres below the patella. So I try and just measure all this stuff with my athletes wherever possible. And you can measure it in whatever way works best in your clinic. But you need to have those benchmarks for your athlete. She could double squat pain-free, and her single leg squat was only 1 out of 10 and 45 degrees. So that was a really good sign for me that we can get her straight into that rehab process. I've mentioned a few times the importance of palpation. Really important to palpate both sides to feel the difference between both sides, and really important, obviously, you're going to know from the subjective whether they've had a previous hamstring injury on either side. So I've had people say, yeah, they didn't have a hamstring injury, but they did have one on the other side. So that's really important to note as well, because that's going to impact the findings that you get on palpation. And you need them to say, is this where you saw, is this where you saw? You need to have a comparison of the sensitivity, as I suggested. And I like to mark the painful area, so I'll get a pen or a marker and mark the distance. So I'll say I work from proximal most of the time to distal, and make a mark where they first feel the pain and then down, and then measure the width of it as well. So I have an overall picture of the distance of that, and then I'll take a photo so that I've got those numbers written down, and I'll share that with them as well, because sometimes that can be a really good sign of progression. There is evidence to say that when the length of the painful area is half that of the original, you are a third of the way through your rehab. And when the painful area is a third of the way, when the painful area is a third, you are halfway through the rehab, so the reverse. So I think that's really fascinating, and like I said before, I think we can't underestimate the power of our palpation.
Yeah, that's really interesting. I hadn't kind of heard that research before, or probably, definitely, I guess, hadn't paid that much attention to that palpation. So really good tips there.
And I think it's just really important, because I'm thinking about all the people out there that are just in their normal clinics, they don't have huge, big assessment facilities like we, people that have amazing force plate facilities and really good isokinetic testing and things like that. The average practitioner doesn't have that. And I've done so much traveling as a physio that I know what it's like to be able to, measure things in hotel rooms and stuff. So I think really important. So palpation for Jala. She was tender on palpation, proximal third of biceps femoris, close to the musculotendinous junction. The distance was 6 centimetres in length by 4 centimetres wide initially, and it was 6 out of 10 on palpation. So you're kind of probably thinking that maybe biceps femoris is the one involved, answering your question from before. In saying that, sometimes you will have tenderness on palpation of the other hamstring muscles, but it'll be distinctly different in terms of the VAS of the muscle that is injured. So if you are finding more than one muscle is tender on palpation, ask them, is this the same pain? And make sure you use that VAS scale or whatever scale you normally use, so that you can differentiate them. So obviously we want to know what's happening in terms of the hamstring flexibility. Passive straight leg raise, we all know what a passive straight leg raise test is. Patient supine, other leg is fixed, and the clinician passively raising the leg and measuring that hip flexion angle. Really important, like I said earlier, always compare. And I will always compare and write down the readings for both sides. And if you're not in the habit of doing that, I would start doing that with hamstrings. We can also measure hamstring extensibility or flexibility with the pain-free knee extension test. So this is an active test. The hip is flexed to 90 degrees, and then the other leg is fixated, and the knee is just gradually extended till there's an onset of pain or resistance. And obviously the knee extension angle is measured.
I think even though these are really simple tests, like you say, they're ones that can be done in most settings, and still having that attention to detail of, how the patient is set up and how you're measuring it is going to give you better quality information. Whereas if you do it a little bit different every time, then you're not really going to be seeing those changes.
100%. And the other thing, like, don't just measure the angle, you can measure the VAS as well, because they might be getting the same level of flexibility, but they've got less pain. So for an athlete that has a really bad injury, trying to give them some point of progression, it's like your pain was 6 out of 10 yesterday or 2 days ago, and now it's 4 out of 10. We're winning, you know. So it's just being able to give them any kind of benchmarks you can that you're going in the right direction. And like I said, that keeps the buy-in for the athlete happening.